are potentially fatal. And we do know that over time, particularly the first several months after the diagnosis, the mortality continues to go up as a function of age. And clearly, this is a problem that we need to do better at. There are a variety of ways of looking at acute pulmonary embolisms, and one of the most common is dividing them up into massive pulmonary embolisms, submass of high risk, and submass of low risk. And it's important to understand that the severity of them, as defined by hypotension, cardiogenic shock, right ventricular dysfunction, or elevation of your cardiac enzymes, ultimately will help, unfortunately, define the mortality that is associated with it. So while a massive pulmonary embolism occurs less than 5% of cases, it is associated with up to a 60% mortality. And while the specific therapies are in constant evolution, as reflected by current society guidelines and evolving technologies, first and foremost is, almost regardless of whether there is shock or not, that anticoagulation is initiated, and long-term therapy often involves either a vitamin K antagonist or some type of newer oral anticoagulant, depending on what is available. However, most guidelines also advocate some degree of reperfusion therapy, and typically with lytic therapy, and there's a variety of options for catheter-directed therapy. But it's important to keep in mind that most protocols include the option for considering surgery in these patients. And my point today is that maybe we should be considering surgery more frequently. One of the challenges is that when we decide who to treat and how to treat them, we have to recognize that while there is a substantial increase in mortality with massive pulmonary embolisms, the bleeding risks are comparable depending on the severity when treated with lytic therapy. And so it becomes a balance of doing great benefit to the patient while avoiding some of the complications, including mortality or intracranial hemorrhage, which then helps us determine which options are best, because some of these other therapies are lower risk. We do know, and this is a very important point, that the long-term survival of patients is often determined whether their right ventricular function normalizes before leaving the hospital. This has been well known and validated for over 20 years now, and there is evidence that systemic thrombolytic therapy has a significant impact in right ventricular dysfunction, and that is really a cornerstone of why we treat these patients, because of the long-term prognosis. However, one of the problems is that the risks of treating with thrombolytic therapy are often comparable to the benefits, and despite all of these studies over time, there really hasn't been a substantial benefit in terms of early and late survival with thrombolytic therapy, in part because of the competing factors of improvement in RV function, which we know is good, offset that by the bleeding complications that are associated with it. And furthermore, I think it is pretty well established that there are a variety of contraindications to thrombolytic therapy, and in fact, many patients have some absolute or relative contraindication, which is ultimately why they develop a pulmonary embolism to begin with, which then raises the question of what next. And that's why the role of surgery is so important. As I mentioned at the beginning of this talk, we're talking about a therapy that is now over 112 years old and first published by Trendelenburg in 1908, when he first proposed the surgical management of acute pulmonary embolism, in part because he was very discouraged by seeing early mothers dying of massive pulmonary embolisms. And he proposed making a small incision, typically in the second intercostal space, to get direct surgical access to the pulmonary arteries and directly extracting the clot. A very novel concept, considering that this was all before the development of even general anesthesia. And interestingly enough, the surgical management of this has not changed much. Over time, similarly challenged by this difficult problem, John Gibbon, who was the forefather of modern circulatory support, actually developed the heart-lung machine with the sole purpose of trying to treat acute pulmonary embolism. Early on, as published in 1937, he attempted this in 142 patients, but only 9 survivors. Nevertheless, this is considered the beginning. As this evolved over time, we started to see improved outcomes with more experience and a better understanding of patient selection and how to treat and manage these patients, particularly those that present in cardiac arrest, potential futility, or in extremis. And in the modern era, most specifically over the past 10 to 20 years, as we are getting better at selecting these patients, more and more studies are coming out to show that a surgical approach to acute pulmonary embolism can have as high as a 90% perioperative survival rate, which is quite comparable to some of the current studies that are out there on catheter-directed or systemic lytic therapy. In fact, a more contemporary study demonstrated a 6% operative mortality in almost 50 patients, again, demonstrating significant improvements in the perioperative selection and management of these patients. Keeping in mind that with modern data and outcomes, we are able to also consider those patients that are not candidates. For example, those patients that have prolonged cardiopulmonary arrest, signs of brain death, unable to achieve a diagnostic CT scan, advanced age is a relative contraindication, as well as what we consider a terminal illness such as decompensated heart failure or advanced cancers or a recent stroke. Obviously, these are all relative and need to be weighed on an individual basis. And also those patients that are improving with medical therapy, it's important to stand back and wait. But one of the things that we noticed is across the board, the surgical outcomes have been getting better. And this is a review of a nationwide experience in over 2,700 patients, emphasizing that the overall mortality is less than ideal at 27% mortality, but keeping in mind that this is a variety of centers across the United States where the average surgical volume or hospital volume per year is often 1 to 2 cases. Clearly, this is an example of the better you get at it, the better your outcomes are. But nevertheless, it is important to keep in mind that surgical management is a reasonable problem or a reasonable solution to this problem. And in fact, over time, as this paper that was published in JACC a couple of years ago, there's been, despite a significant increase in the number of pulmonary embolisms as illustrated on the blue line going up over time, there has been a substantial, if not greater than 50% improvement in the overall surgical mortality, going from about 32% at around 2004 to more contemporary series that are demonstrating a 10 to 14% mortality in this critical ill population, which is comparable to what we're seeing in high-risk catheter-directed therapies. And most importantly, we're also seeing an improvement in the markers of the long-term prognosis, and that is specifically an improvement in the pulmonary artery pressures, the right ventricular to left ventricular ratios, and overall right ventricular contractility, which is demonstrating that surgery is associated with a significant improvement in those parameters of right ventricular function that ultimately do translate into improved, not just short, but long-term outcomes for this critically ill population. So overall, as we start putting this together, a recent paper a couple of years ago, again in JACC, looking specifically at the surgical management of pulmonary embolism compared to medical therapy, showed a substantial improvement in outcomes, with surgical management having a 1% mortality compared to optimal medical therapy at over 11%. And in fact, when you stratify those patients that are getting CPR versus no CPR, it does demonstrate that the surgical outcomes in this population is still acceptable despite the substantial risks of taking somebody with CPR in progress to the operating room, with a 21% mortality in patients that otherwise would have died without any therapy. And so that allows for the development of these algorithms that are supported by current guidelines, in which whenever there is consideration, whether it's for high-risk patient populations, whether there's ongoing CPR, or whether there's patients that you're considering for catheter-directed therapy, you should at least engage the surgical team to see if surgery is a potential better option for these patients with regards to considering the contraindications as well as the overall risks of thrombolytic therapy in a high-risk population. One of the things I just want to touch on before we conclude is that surgery also is a potential option for those patients that have already failed thrombolytic therapy. We know that a small percentage of patients end up still deteriorating despite thrombolytics in both catheter and systemic. And rather than subjecting them to repeat catheter or repeat thrombolytic therapy, which we know is associated with a substantial risk, we see a twofold improvement in the overall outcomes if those patients are taken to surgery instead. In other words, there's a substantial improvement in survival with fewer major complications with surgical management of these patients who initially fail a trial of thrombolytic therapy, again, illustrating the conversations need to be had. So in conclusion, I want to emphasize the importance of having a pulmonary embolism response team. There has to be a high index of suspicion when you're evaluating patients with massive or submassive pulmonary embolism, early and aggressive therapy, including anticoagulation, risk assessment and monitoring, specifically for the development of shock and RV function, monitoring patients even with hemodynamics when you're subjecting them to either systemic or catheter-directed therapy, and you need to consider surgery at all points in the decision tree. And with that, using this multimodality therapy and pulmonary embolism response teams improve outcomes come over time with timely and aggressive therapies. And again, I want to thank my colleagues in Vietnam for the opportunity to present on this topic, and hopefully we'll have time for questions either now or later on in the session. Thank you very much, and have a nice day.
Thank you, Dr. Michael Fitzenberg. I think this is a very interesting presentation. In Vietnam, we have the team PERT just 1 year only. I want to know in your center, when do you establish the PERT in your center?
Right, and I think the important thing is, particularly with a lot of the pulmonary embolisms that we see with COVID, that anybody that comes in with anything more than just a simple, uncomplicated pulmonary embolism, we start engaging in the conversations of the team. So all of these patients should be getting ultrasounds to look at right ventricular function. They should be getting cardiac biomarkers, including looking at brain natriuretic peptides and troponins, looking for right ventricular strain. And when you have evidence that you're dealing with something more complex, such as a submassive pulmonary embolism, physiologically or based upon CT scan imaging, if possible, then that is the time that you need to engage the team and talk about what the options are.
Thank you. And I want to know how many % of the PE patient in your center have an indication for surgery to remove the thrombus in the pulmonary artery?
Well, with the expertise and availability of catheter-directed therapies, we're probably seeing less than probably 15 to 20% of patients being considered for surgery, and probably, I would say maybe about 10 to 15% actually go on to surgery. We're doing a lot less surgery these days because the catheter-directed therapies, whether it's lytic therapy or some of the aspiration or morselization therapies, are becoming so successful.
Yeah, so in your center, about 15 to 20% of the patient have a indication for surgery. I want to know more detail. How many % of the patient have a contraindication for thrombolytic therapy, and how many % of patients fail to the thrombolytic therapy?
Sure. So we probably see maybe about 40% of patients have some degree of a relative contraindication to thrombolytic therapy. But again, I think as people are becoming more confident with some of the current catheter-based therapies, we are pushing the envelope a little bit. And so even if somebody has had, let's say, recent trauma or recent surgery, meaning in the past couple of weeks, there is a very low threshold for taking them to the cath lab or interventional radiology. And that's why more and more of these patients are going for non-surgical options. And we are seeing very few of them, probably less than 10%, fail thrombolytic therapy. And part of that also is, unfortunately, some of those patients, when they fail, they end up having a cardiopulmonary arrest. And if it's in the middle of the night, even if the team is aware of them, the salvage rates of those populations, unfortunately, are quite low. And I think that's why it's important to have these conversations early on in the therapies to at least identify those patients that we need to be much more aggressive with in terms of how we're managing them. It's a real problem to kind of come in the next day and find out that a patient that you had heard about that you thought may have been a good candidate for surgery may have died in the middle of the night. And we do see that on occasion, and it's very difficult for everybody.
Thank you, Dr. Michael Fitzenberg. I think we learned a lot from your presentation, and because of the time limit, so thank you very much. We will move to another, the next presentation. Thank you.
Thank you. My pleasure. Thank you.
And the next presentation is from Associate Professor Fowler Latif from Oklahoma in USA. We just have a video for the presentation only. So, okay. Mình chiếu cái video của bác sĩ Latif đi em ạ. Cái này chúng ta chỉ có cái video thôi, không có báo cáo viên tham dự với chúng ta.
So the risk stratification here in this graph is shown that the asymptomatic patients are about 40% and their mortality is fairly low. Then the patients who do not have any RV dysfunction and have a negative troponin and BNP, they are a higher strata. Who are in shock. And then intermediate risk or the submassive patients are the ones who have an impact on their RV and they have a positive troponin and or a positive BNP. So it is important to risk stratify them based on their blood pressure, heart rate, and whether to categorize them in the low risk patients or submassive patients or massive pulmonary embolism patients. Because this impacts their mortality. Patients with massive pulmonary embolism have a greater than 30% mortality in the hospital. How to risk stratify them? So this PESI score comes in very useful. It takes into account patients' age, whether they have cancer or not, lung disease, their pulse, their blood pressure, and other features, and calculates a PESI score. So if the score is less than 85, they are low-risk patients. If the score is more than 125, they are very high-risk patients, and therefore they can be managed accordingly. The therapies that are available for these patients, as we all know, are systemic anticoagulation, caval interruption like inferior vena cava filters, systemic thrombolysis, catheter-directed thrombolysis, or surgical embolectomy. So the rationale for advanced therapy is to try to catch patients who are in this strata, who are in the intermediate risk, that have their RV affected by the pulmonary embolism hemodynamically, and that they are not very sick, how to manage these patients and how to improve their outcomes. I'm going to start talking about the systemic thrombolysis. Previously, an older study looked at doing thrombolysis for all patients coming in with pulmonary embolism. And what was found was that there was no difference in outcome between thrombolysis and heparin groups. However, the patients who received thrombolysis definitely had a much higher risk of bleeding. Therefore, not everyone who's coming in with pulmonary embolism needs thrombolysis. Only the high-risk patients do. The submassive patients are the ones that are in the gray zone. They have a lower mortality of around 5%. And also, these are the patients who actually are more likely to survive, but their quality of life may be affected because they may develop CTEPH, that is chronic thromboembolic pulmonary hypertension, and anything to reduce the incidence of that would be helpful. The data that we have on these patients who have submassive pulmonary embolism are from these trials. The PATHO and TOPCOAT evaluated the full dose thrombolysis, MOPET evaluated the safe dose, which is the half-dose thrombolysis, and Ultima evaluated the catheter-directed thrombolysis. So PATHO was a trial to investigate the efficacy of tenecteplase in patients with intermediate risk pulmonary embolism. The primary outcome was death within 7 days, and then the safety outcome was major bleeding within 1 week, or any stroke less than 1 week. And what was found is that the primary endpoint improved significantly in patients who received TNK. There was definitely a major bleeding risk increased and hemorrhagic strokes increased. However, their overall outcome was better if they received full dose thrombolysis. The elderly patients actually were the ones who had the worst outcomes. That is, if the age was more than 75, the benefit was not there. They crossed this line of unity. Age less than 75 were the patients who actually benefited from systemic thrombolysis. So how can we improve the care of these patients? The catheter-based therapies are widely available now. Like this is an ECOS catheter, that is an ultrasound-mediated thrombolysis catheter that with the ultrasound breaks down the clot. This is an angiojet. Just using a pigtail catheter, this is the cheapest way of doing it, pigtail catheter, rotating it and macerating the clot, and so on and so forth. The rationale for use of these catheters is that you can actually remove the cause of pulmonary embolism, that you are removing the thrombus. There is quicker return of normal pulmonary blood flow. And also when you infuse the thrombolytic through these catheters into the pulmonary artery, the clot sees a higher concentration of thrombolytic agent. A lower dose of thrombolytic agent may be infused typically 20 milligram or less with this as compared to systemic, which is a much higher dose. And also the risk of bleeding is likely to be lower. Here is a case example where this patient is a 42-year-old female with submassive pulmonary embolism. There you can see pulmonary embolism on the CT scan in the right pulmonary artery and the left pulmonary artery. Here is some thrombus in transit also. This is in the right atrium, you can see a big clot that's flopping. Here you can use this angiovac system, which is a veno-venous bypass, and you can advance this catheter and suck out this clot and help the patient. Then there is suction thrombectomy that can be used with the angiovac, and you can get out very large amounts of clot with this catheter. Ultrasound-assisted catheter-directed thrombolysis, where ultrasound causes disaggregation of fibrin within thrombus, and there is increased penetration of the thrombolytic agent into the clot, and therefore it can be more effective. So here in this patient, you can see that this is a pulmonary angiogram, and you can see the large clot here. And then this is a ECOS catheter that is part, this is in the right lung, this is in the left lung. Both sides have thromboembolism, and basically that can help these patients a lot. So this was a study by Kutcher published in Circulation back in 2014, where Ultima, which was the ultrasound-assisted thrombolysis for submassive pulmonary embolism, and the aim was to look at whether this strategy is superior in reversing RV dysfunction in these patients. And the primary outcome was the change in RV-LV ratio on the CT or the echocardiogram at 24 hours, and the safety was going to evaluate death and bleeding and recurrent venous thromboembolism. The dose that was used was 1 milligram per hour for 5 hours, then 0.5 milligram per hour for 10 hours in each lung. The maximum dose per patient was 20 milligram, and the follow-up duration was 3 months. Here is the schema. Basically, the patients were randomized to either receive this ultrasound assisted catheter-directed thrombolysis with heparin versus heparin alone. And what was found, most importantly, that RV dysfunction, the severe RV dysfunction was much less in patients who received ultrasound-assisted thrombolysis compared to heparin. So therefore, it was found to be beneficial in this regard. Now, importantly, this was not a clinical outcome study, and therefore we don't have hard outcomes based on this data, except that there are small numbers here that did not show any difference. This study was a small study, was not powered to look at all these hard outcomes. The treatment strategy based on the bleeding risk is important in patients who have massive or submassive PE, but are at high bleeding risk. Like, for example, they have thrombocytopenia, they have had recent GI bleeding, they have had a stroke in the past, and so on. Then actually using a catheter-directed thrombolysis could be a better strategy to reduce the risk of their bleeding. And also there are devices now, for example, the penumbra catheter, where you don't need to use thrombolysis. You can just use endovascular thrombectomy with the penumbra, or you can use any other catheter, to try to minimize the risk of bleeding and improve their outcomes. Also, if the patients have a high bleeding risk and cannot be anticoagulated, placement of an inferior vena cava filter can be very beneficial. If patients have a low bleeding risk, then systemic thrombolysis can be considered strongly in addition to regular anticoagulation. So summary of my talk is that systemic thrombolysis improves mortality in patients with massive pulmonary embolism. Systemic thrombolysis improves the composite endpoints in submassive pulmonary embolism, but this is at a cost of somewhat increased bleeding. Therefore, we need to keep in mind that the catheter-directed thromboembolism or thrombectomy devices like penumbra and things like that without thrombolysis might actually be helpful for these patients. Alternative dosing and delivery strategies have met surrogate efficacy endpoints and avoided the bleeding penalty. And also the interventional treatments can be considered for patients who may even have massive PE, but are at higher bleeding risk with systemic thrombolysis, and therefore can benefit from catheter-directed thrombolysis or endovascular thrombectomy. Surgical embolectomy is also an option in patients who have large amount of clot and are candidates for surgery. Thank you very much for your attention, and thank you for the invitation.
Okay. Associate Professor Latif, do you hear me?
Yes.
Yeah. So thank you very much for your presentation. I want to know what kind of device using for TEN catheter therapy in your center?
Generally, we're using a lot more penumbra these days. Because penumbra, we're having good success with that without the use of TPA. Because whenever you give TPA, there is some risk of bleeding. So penumbra has been the predominant device that we are using these days.
So in your center, you have the team, PERT team, in your center to manage the patient?
Honestly, we do not have a very well-developed team. Actually, it's ideally the team should constitute a vascular medicine specialist, a pulmonologist, and a surgeon. So, even though we heard a very nice presentation from Dr. Kirstenberg, many centers do not have a surgeon who does these thromboembolectomies. So we do not have a comprehensive surgeon. But having said that, yes, we do coordinate with pulmonologists and sometimes hematologists to help these patients with thrombolysis and choose patients who are the ones who can have systemic thrombolysis, who are the ones who just need anticoagulation, and who are the ones who can have either catheter-directed thrombolysis or just thrombectomy, section thrombectomy.
Yeah. Okay. So we know that to manage the PE patient, we have a medical treatment. For example, just give them the thrombolysis therapy, systemic thrombolysis therapy only. We can use surgery to remove the thrombus, and we can use catheter therapy for them. So, how many percent the patient in your center receive the catheter therapy?
If I understood it right, you're asking how many patients, what's the percentage of patients in our center who go for this catheter-directed thrombolysis?
Yeah.
Yeah, so that's probably about 15 to 20%. 80% of patients do not go to the catheter.
Yeah, thank you. So, sometimes we have to infuse infusion to make infusion the RTBA for the patient via the small catheter to the pulmonary artery. So you do like this or not? In my country, in my center, we use a catheter, small catheter into the PA, the pulmonary artery, and a small dose of RTBA, thrombolytic agent. And we found that this is a good way for the country like Vietnam. So in your country, you do the thrombolytic therapy. It means that directly to the pulmonary artery or not?
We do use that at times, that we use a catheter that we just park there and give TPA maybe 1 milligram an hour for 6 hours, and then half milligram an hour for 10 hours, and then bring the patient back and recheck their pulmonary pressure.
Yeah, thank you. But I want to know how many hours we have to wait from infusion when we give TPA into the pulmonary artery, and we check the angiogram, the pulmonary angiogram again. How long?
So 12 to 24 hours. But we do not repeat an angiogram when we bring them back. We only repeat the pressures. We do not do an angiogram again because, the clot may still be there, but the hemodynamics may have improved.
Yes, thank you. Các bạn có câu hỏi nào cho Associate Professor Latif không ạ? So thank you, Associate Professor Latif. We don't have time to more discussion, and we will move to a next presentation. Thank you very much.
Thank you.
Okay, so. Yeah. Các bạn có câu hỏi nào cho báo cáo viên này không ạ?
Bởi vì cái báo cáo viên thứ ba đó các bạn, theo chương trình đó thì thấy chưa có gửi video cho chúng ta và cũng không có vào Zoom để mà chúng ta có thể nghe được một cái bài báo cáo mà tôi nghĩ rất là hay, rất là một cái chuyên đề trong. Thì khi nào mà chúng ta sẽ đặt stent tĩnh mạch cho những cái trường hợp nào? Thì các bạn có ý kiến gì về trong cái phần trình bày vừa rồi không ạ? Mời em.
Alo, em kính thưa thầy Bình, kính thưa các thầy cô, các anh chị. Thì lúc nãy giờ mình đã nghe hai cái chuyên gia người Mỹ người ta trình bày về cái chuyện điều trị cái huyết khối động mạch phổi cấp tính. Khi nào thì mổ, khi nào thì hút huyết khối hay là điều trị bằng tiêu sợi huyết. Báo cáo thầy Bình ấy, thì em là bác sĩ Sơn làm việc ở trung tâm tim mạch lồng ngực bệnh viện Hữu nghị Việt Đức. Còn em thì có cái số lượng bệnh nhân chấn thương khá là lớn. Những cái bệnh nhân này ấy, thì thường là có đa chấn thương kết hợp với cả chấn thương xương chi, cho nên là bệnh nhân nằm là bất động, và trên cái nền mà của bệnh nhân đa chấn thương thì là người ta không dùng được cái thuốc chống chấn để mà phòng, và có gãy xương nữa, cho nên là người ta cũng rất là khó khi mà dùng các cái phương pháp cơ học để mà phòng tránh cái bệnh mà huyết khối tĩnh mạch sâu. Chính vì thế mà cái số lượng bệnh nhân bị cái huyết khối tĩnh mạch sâu và sau đấy thì thuyên tắc phổi là khá là lớn. Thì ở Việt Đức thì đã có đến hơn kinh nghiệm hơn 10 năm về điều trị cái này bằng ngoại khoa. Báo cáo thầy Bình thì những cái bệnh nhân mà bị massive pulmonary embolism thì bọn em không thể dùng tiêu sợi huyết được, cho nó chảy máu khi mà có cái đa chấn thương gan thận kèm theo. Vì thế nên bọn em mổ thì thấy rằng là cái kết quả rất là tốt. Đấy, thì sẽ thường mổ có bypass và dùng cái thuốc và lấy huyết khối. Cái phần về cái dùng cái catheter để hút huyết khối thì ở Việt Nam thì nó thường là cũng đang ít không mà có được cái đầy đủ dụng cụ nhất của bên người Mỹ đấy, cho nên là cái việc đôi khi triển khai cái hút huyết khối qua cái catheter ống thông đấy là cũng khá là khó khăn. Bây giờ thì cái điều kiện mà các cái máy móc thiết bị thì tốt hơn thế, nhưng mà cũng không phải khi nào cũng có thể làm cấp cứu được. Vì thế cho nên là nếu mà những cái trường hợp mà hối động không ổn định, những trường hợp mà có thuyên mà động mạch phổi thì phẫu thuật cũng là một lựa chọn. Và phẫu thuật thì bọn em nghĩ rằng là không có cái liều chống cũng 300 đơn vị trên cân nặng như thường quy trong một trường hợp, mà bọn em sẽ test cho bằng cái liều 200 trước, và nếu như đủ ACT trước thì bọn em sẽ mổ và không cho cái thời gian ACT quá để cho tránh những cái biến chứng mà chảy máu trong bệnh nhân đa chấn thương. Vâng, thì cái tỷ lệ là bệnh nhân mà cứu được rất là nhiều, và cái tỷ lệ tử vong rất thấp. Bọn em mà có cái báo cáo trong những cái hội nghị trước.
Cảm ơn em. Vì đây là cái câu hỏi Việt Nam của mình bằng tiếng Việt Nam đó, thì xin mời bạn phiên dịch dịch cái ý đó cho hai báo cáo viên, để hai báo cáo viên vừa rồi đó có thể là cho thêm ý kiến em ạ.
Good morning, Professor, and I am a doctor from Việt Đức University Hospital. I want to share our experience on the pulmonary embolism treatment. In our country, is just we have not enough equipment for catheter-based thrombo aspiration, and especially in our hospital, our hospital is biggest surgical center with multi-trauma patient and we have a high number of patients with acute pulmonary embolism. In case with massive pulmonary embolism, we prefer surgery with the cardiopulmonary bypass, and we do not stop the heart during operation. We do thromboectomy on beating heart, and the result is good. During the last 10 years, we have about 25 cases, and the mortality rate about lower 5%. And I think surgical pulmonary embolectomy from pulmonary artery is feasible in the center where the catheter aspiration is not available and or limited. Thank you very much.
Cảm ơn em. Tôi nghĩ là bệnh viện Việt Đức là bệnh viện chuyên về phẫu thuật đó. Thì cái xu hướng của điều trị về PE, chúng ta thấy là nếu phẫu thuật thì như là giáo sư bác sĩ Michael Fishenberg vừa nói đó, thì chiếm tỷ lệ chỉ có 15 đến 20% là chỉ định phẫu thuật. Như vậy khoảng 70-80% số bệnh nhân còn lại đó thì chúng ta phải có những cái biện pháp điều trị khác là thích hợp hơn. Đó là cái chuyện mà chúng ta điều trị mà thông qua catheter, có nghĩa là thông qua can thiệp nội mạch đó các bạn. Như vậy thì bệnh viện Việt Đức á, thì hay là những cái bệnh viện khác vân vân đó, chúng ta cần phải phát triển cái phần mà điều trị thông qua ống thông, transcatheter therapy for PE patient. Tại vì chúng ta thấy rằng nó ít xâm lấn hơn và nó cũng giải quyết được một số bệnh nhân rất quan trọng, và đó là một cái kết quả, một cái xu thế trên thế giới. Vì vậy cho nên là chúng ta phải phát triển đều đặn hết. Một mặt là chúng ta phải cải thiện thêm về cái kỹ thuật của chúng ta trong mổ. Các bạn thấy đó, như là thống kê mà bác sĩ Michael có nói với chúng ta đó, từ năm 2004-2005 tỷ lệ tử vong của những bệnh nhân phẫu thuật chúng ta tới 32%. Nhưng mà tới nay đó 2015-2016 thì cái tỷ lệ tử vong do phẫu thuật đó nó chỉ có
That's a very good question, because the short answer is that over the years we have done a few very high-risk patients that have very strong contraindications to lytic therapy. I think the issue is, while putting them on cardiopulmonary bypass is not without risks, surprisingly many of those patients actually do quite well. And I would not hesitate in potentially operating on somebody that had multi-trauma, with maybe the exception of a substantial head bleed like a subdural or epidural hematoma. As many of the surgeons in this room may know, bleeding is sometimes easier to deal with than clotting. And if the patient has a bleeding complication after surgery, then sometimes that's a lot easier to deal with. The real problem comes in is that these patients still need systemic anticoagulation therapy, and even some of the early protocols for these high-risk patients would advocate putting in a filter in the immediate perioperative period because of the high risk of repeat pulmonary embolisms. And when we first started doing these at my center years ago, we would often go right from the operating room down to radiology to have the filters placed. And over time, we did that later and later. So the answer is yes, I would consider operating on some of these very high risk patients, recognizing that that may be their only chance for either survival or a good outcome.
Thank you for your advisement. Các bạn khác có ý kiến gì thêm không? Các bạn có thêm ý kiến gì để hỏi thêm các báo cáo viên không? So, Dr. Michael Fishenberg and Associate Professor Faisal Latif, in the program we have two more presentation, but now we don't see the video from Dr. Miha Kosan and another presenter. So maybe we don't have any the presentation anymore, and we just have a more discussion in this section. But in the audience, we don't receive any question from the audiences. And do you have the more advancement for us when we manage the PE patient?
Yeah, if I can I comment? You know, I think the emphasis really should be developing a response team so that each individual patient can be discussed, recognizing the therapies that may be available at individual programs. As my colleagues have mentioned, not every surgeon feels comfortable doing surgery, even though the surgery is relatively straightforward and can be learned pretty easily. But we also need to recognize that not every center also has access to some of these very expensive and advanced catheter-directed therapies, although sometimes even just floating a catheter into the pulmonary artery, like a pulmonary artery catheter, and doing local lytic therapy may be better than doing nothing. And so the key is when you identify these patients, look at the team that you have, the resources, the skills, as well as the issues with the patient, and do whatever you can to try to get the clot out. Because we know if the patients bleed with RV dysfunction or residual clot in the pulmonary arteries, that really sets them up for a high risk for developing either heart failure problems, premature mortality, or chronic thromboembolic disease, all of which can be very difficult to manage long term.
Thank you. Thưa các bạn, thì chúng ta có một cái section là tôi nghĩ rất là lý thú, rất là hay đó. Vì sao nói như vậy là tại vì trước đây là ở Việt Nam chúng ta vẫn suy nghĩ trong đầu rằng cái việc mà thuyên tắc huyết khối tĩnh mạch và bị thuyên tắc phổi đó, PE đó, nó hiếm lắm, hiếm ở người Việt Nam chúng ta. Nhưng mà thật sự trong những năm gần đây đó, ở Việt Nam thì số lượng mà bệnh nhân bị PE rất là nhiều. Lúc trước có lẽ là cũng bị nhiều, nhưng mà chúng ta ít có phương tiện để mà chúng ta có thể phát hiện được. Ngày nay mà với phương tiện là chụp CT rất là rộng rãi trong bệnh viện của chúng ta đó, thì chúng ta phát hiện rất là nhiều những cái ca bị PE. Và khi mà phát hiện nhiều như vậy thì chúng ta phải có cái chiến lược điều trị. Thì đầu tiên nhất là chúng ta phải có những cái đội gọi là đội phản ứng đối với PE, viết tắt cái chữ gọi là PERT, tức là PERT, tức là PE xong là response team, một cái đội ngũ như vậy để đáp ứng nhanh. Thì trong cái đội ngũ đó người ta khuyên là chúng ta nên có một người bác sĩ nội khoa về tim mạch, một bác sĩ can thiệp tim mạch, một bác sĩ phẫu thuật tim mạch, một bác sĩ về gây mê và một bác sĩ về chẩn đoán hình ảnh. 5 bác sĩ đó chúng ta sẽ thành lập một cái team. Và khi bất kỳ có cái dấu hiệu nào mà có PE xảy ra trong bệnh viện đó, thì chỉ trong vòng 15 đến 30 phút là cái đội ngũ đó đã có đủ trong bệnh viện rồi. Và thông qua cái sự thảo luận đánh giá xem là bệnh nhân này là massive PE hay là submassive PE, high risk hay là intermediate risk, thì tất cả những chuyện đó và đánh giá cái nguy cơ chảy máu của người bệnh. Khi mà chúng ta đánh giá xong rồi chúng ta mới có cái chỉ định. Một là chúng ta dùng tiêu sợi huyết, đường tĩnh mạch toàn thân, systemic thrombolytic therapy. Còn hoặc là chúng ta, nếu mà chúng ta thấy rằng là chúng ta thất bại với cái systemic thrombolytic therapy đó, hoặc là bệnh nhân có nguy cơ chảy máu cao, có chống chỉ định đối với lại thrombolytic therapy, thì chúng ta sẽ tiến đến cái chuyện mà phẫu thuật để mà chúng ta lấy huyết khối ra. Thì theo cái số liệu của Dr. Michael Fisenberg thì chúng ta thấy nó chỉ từ 15 đến 20% thôi. Còn lại những trường hợp thì chúng ta có thể tiến hành chúng ta lấy huyết khối thông qua cái đường catheter. Và chúng ta biết rằng là trong những năm qua thì có rất nhiều cái dụng cụ lấy huyết khối qua catheter này đã được FDA approve, được chấp thuận để mà sử dụng đó. Thì đầu tiên chúng ta thấy đơn giản lắm, chúng ta đưa một catheter vô, xong rồi chúng ta dùng cái lực hút, có thể hút bằng tay manual aspiration, chúng ta có thể hút bằng tay, chúng ta lấy ra được một số huyết khối cũng khá là nhiều, và nó cũng thông thương được. Mục đích là chúng ta làm đỡ cái tắc nghẽn trong cái động mạch phổi của chúng ta. Sau đó thì chúng ta thấy là có những dụng cụ cũng khá hơn, là chúng ta đưa cái dụng cụ vô đó, xong rồi chúng ta dùng cái siêu âm để chúng ta khuấy nát cái huyết khối đó chút xíu rồi chúng ta hút ra. Và thậm chí sau này chúng ta có những cái dụng cụ gọi là giống như là angiojet valve, thì chúng ta đưa cái dụng cụ đó vô mà tương đối khá lớn, có một lực hút khá mạnh. Khi hút ra xong rồi cả máu rồi luôn, người ta đưa vô một cái pin, người ta lọc xong rồi người ta lại truyền cái máu đó vô trở lại trong người của người bệnh. có nghĩa là chúng ta lấy bớt những cái huyết khối bự rồi và chúng ta truyền trả lại máu cho người bệnh thì nó cũng có kết quả rất là tốt. Và cũng có thông qua một cái catheter như vậy, như cái bài trình bày của Professor Fazal Latif thì chúng ta có thể đưa một cái catheter nhỏ, nhiều cái lỗ trong đó vào trong cục huyết khối, chúng ta truyền cái liều mà ATPA, một loại gọi là thrombolytic agent đó, thì liều nhỏ nhỏ từ từ để cho nó tiêu cái huyết khối đó từ từ, và sau đó chúng ta chụp lại CTA để mà chúng ta xem cái độ thông thoáng nó bao nhiêu, vân vân. Để xem là chúng ta có thành công hay không. Nếu thất bại thì có khi là chúng ta phải phẫu thuật. Và như vậy thì chúng tôi thấy rằng là ngoài cái phương tiện mà truyền tiêu sợi huyết mà đường toàn thân đó, chúng ta có phẫu thuật, chúng ta có điều trị transcatheter based therapy, tất cả những cái điều đó thì mang lại kết quả tôi thấy là càng ngày càng tốt hơn cho những cái bệnh nhân mà bị thuyên tắc huyết khối tĩnh mạch và bị PE. Thì đó là những cái phần mà tôi nghĩ là tóm tắt trong cái phiên vừa rồi. Hai bác sĩ ở Hoa Kỳ, USA, tôi nghĩ là có những cái bài báo cáo rất là tốt, rất là tập trung để cho chúng ta biết là khi nào chúng ta có chỉ định phẫu thuật, khi nào chúng ta có cái chỉ định để mà chúng ta lấy huyết khối qua đường catheter, và những cái loại dụng cụ cũng như là cái kỹ thuật chúng ta làm như thế nào để đạt được cái kết quả tốt nhất. Về cái phần thứ hai đó là cái việc mà chúng ta đặt stent tĩnh mạch cũng như là huyết khối ở mạch tạng, ví dụ như là ở tĩnh mạch tạng của chúng ta thì chúng ta làm gì, thì hai bài báo cáo này chúng ta thấy là chúng ta không có được nghe. Hy vọng rằng trong những cái dịp tới thì chúng ta nghe được những bài này. Đại diện cho ban tổ chức thì tôi xin gửi lời cảm ơn đến bác sĩ Michael Fissenberg và phó giáo sư Fazal Latif đã đóng góp cái bài báo cáo cho hội nghị của chúng ta, và những cái lời khuyên cũng như là những cái phần tóm tắt của hai bài báo cáo này đã giúp cho chúng ta trong thực hành lâm sàng rất là nhiều. Xin cảm ơn các bạn cũng đã tham dự cái phiên hôm nay. Thì tôi xin chấm dứt cái phiên của mình ở đây sớm một chút vì chúng ta không có hai bài báo cáo. Thank you, Dr. Michael Fissenberg and Associate Professor Fazal Latif, because we don't have a full presentation after you, so we finish our session. And thank you very much for joining with us in this section. Thank you.
Thank you very much, everybody. Have a wonderful day.
Thank you.
Chắc là chúng ta nghỉ sớm một chút ha.
It's a brand new day. It's a brand new day.
Un, dos, tres, y...
Science, no matter how advanced, is only as meaningful as the lives it transforms. At Boston Scientific, more than 30 years of meaningful innovation has saved and improved millions of lives through pioneering treatments for coronary and peripheral artery diseases, digestive diseases, urinary and women's health disorders, and abnormal heart rhythm.
For 3 decades, we have dedicated ourselves to meet the health needs of every person on our planet. Today, as the world evolves, we see that the human-health relationship is more connected and more conscious. We see new and different health needs that require more science. Hetero is transforming with a renewed focus on people above all else, with a new identity. To create a bigger impact, shaped by warmth and passion, and our commitment to science with a renewed purpose of inspiring human belief in a healthier world. Say hello to a healthier world. Say hello to the new
đã có mặt và đồng hành cùng bác sĩ và bệnh nhân Việt Nam từ năm 2016. Là ức chế SGLT2 đầu tiên được phê duyệt chỉ định cho bệnh nhân đái tháo đường tuyếp 2. Chặng đường nghiên cứu và phát triển được tiếp bước. Đến năm 2018, thử nghiệm Digletimine 58 được công bố. Dapagliflozin cho thấy lợi ích bảo vệ tinh thần cho bệnh nhân đái tháo đường tuyếp 2, dù đã có bệnh tim mạch hay chỉ mới có các yếu tố nguy cơ. Cũng từ thử nghiệm Digletimine 58, các cơ chế mang lại lợi ích trên suy tim của Dapagliflozin dần được làm rõ như tăng thải natri niệu, giảm tiền tải, hậu tải, giảm áp lực lọc cầu thận, bảo vệ thận, cải thiện chuyển hóa tại tim, giảm phù thể tích và kẽm. Đến năm 2019, thử nghiệm DAPA-HF được công bố tại hội nghị ESC, khẳng định lợi ích trên lâm sàng của Dapagliflozin giúp bệnh nhân suy tim đạt được cả 3 mục tiêu điều trị cốt lõi. Với hiệu quả được chứng minh từ cơ chế đến thử nghiệm lâm sàng, tháng 5 năm 2020,
FDA chính thức phê duyệt dapagliflozin trở thành ức chế SGLT2 đầu tiên điều trị bệnh nhân suy tim có hay không có đái tháo đường. Từ lợi ích giảm tử vong, nhập viện, dung nạp tốt và ít ảnh hưởng lên huyết động của bệnh nhân suy tim. Tháng 8 năm 2021, các ức chế SGLT2 dapagliflozin được Guideline suy tim ESC khuyến cáo dùng sớm cùng với các nhóm thuốc nền tảng để giảm tử vong cho mọi bệnh nhân suy tim. Ngày 28 tháng 3 năm 2022, cục máu đánh dấu dapagliflozin chính thức được Cục Quản lý Dược Việt Nam phê duyệt cho điều trị bệnh nhân suy tim phân suất ống máu giảm có eGFR trên 30ml trên phút. Khoa học luôn cải tiến không ngừng, từ bước tiến của các hoạt chất mới, của các thử nghiệm lâm sàng, đến thay đổi cách mạng trong khuyến cáo điều trị suy tim để đáp ứng mong mỏi của bệnh nhân. Hạnh phúc không phải là điểm đến, hạnh phúc là một hành trình. Và giờ đây, hành trình đó được tiếp nối để đồng hành cùng bệnh nhân suy tim của các bác sĩ tại Việt Nam, giúp bệnh nhân được sống lâu hơn, sống tốt hơn và sống bên cạnh người thân và gia đình.